All right, we are ready.
All right.
All right. Well, welcome everybody to Treatment Tuesday. I'm Suzanne Smith-Rowley, and together with Zoe Mayu, we want to welcome everybody to this Treatment Tuesday webinar. This is part of a series, and Southpaw Enterprises generously offered to sponsor this series for us, and we're down the home stretch on the series. We've got this amazing one today with our speakers, Dr. Beaudry and Dr. Bauman, and then we have one more in December. It'll be our special Christmas holiday edition. So yeah, and then we move on to trying to get our International Congress completely buttoned down, which is coming in July. You'll hear more about that. But anyway, we're just so pleased, honored, and delighted that all of you can be here today. I'm going to pull up my little PowerPoint, and Zoe can introduce our speakers.
Okay, great. Well, thank you, Suzanne, and thank you to the whole Classy team and to Southpaw again for your sponsorship of this series, and to all of our participants. It's always so heartwarming to see how so many of you make the time to join us and to have a chance to share information around Ayres sensory integration from all over the world. It's amazing to see all the countries. So today is really special. We have two amazing speakers that I think we feel very honored and lucky to call colleagues and friends. I'm very happy to introduce Dr. Margaret Bauman. We've known Dr. Bauman for so long, and I want to say that you have really changed my life with your work. I mean, you have translated such important research in so many practical ways that have helped therapists, and you have supported therapists so fully. So I just want to thank you for that. You can see her many titles. Dr. Bauman is a pediatric neurologist, and she is working in Massachusetts. And also we are so lucky that she's been spending time in California at Casa Colina Centers for Rehabilitation. She's an associate professor at Boston University School of Medicine, and where she conducts research in a laboratory, and some of her research, all of her research has just been so instrumental for all of us in a greater understanding of autism. Dr. Bauman established the Ladders program, and she's helped families and children in so many ways. I think, we've often felt that Dr. Bauman has so much in common with Dr. Ayres in terms of being such a gifted clinician, in addition to being a researcher and an educator. She's more recently become the medical director of 3L Place Life College, a new program for empowering young adults with developmental disabilities, including autism, to develop more meaningful, productive lives in the community. And we know of her research, many publications, many awards. We couldn't possibly capture everything. So we're just so fortunate to have Dr. Bauman with us today. And we will also at this time introduce Dr. Isabelle Beaudry. I'm not trying the last name. I'll let her say it herself in a moment, but so lucky to have Isabelle Beaudry with us. She's been practicing as an occupational therapist for close to 30 years with specialization in pediatrics and sensory integration, and is currently the owner and director of a clinic in Spain, in Oviedo. She has her training, truly global training, starting in Canada with some advanced graduate study at Thomas Jefferson University, and then a master's degree at Virginia Commonwealth, and more recently and finally her PhD from University of Newcastle in Australia. And Isabel's been so brave in taking on the important research around toileting habits, and a topic that hasn't always been easy for everyone to think about and discuss, but she's added so much to our understanding of this important area of physiology. So we are just thrilled. I mean, both Dr. Bauman, Dr. Beaudry have made so many contributions, and we feel so fortunate to have you both with us for this Treatment Tuesday. So I'll turn it over to you, Isabel.
All right,
Thank
and
you.
while Isabel is getting ready, I just want to remind everybody to stay till the end because we have a raffle for those of you who are here present at the end. And I'm just really looking forward to these presentations, more thinking about health and wellness and life, real life. So Isabel, go ahead.
Okay, thank you. It's such an honor for me to be here. And I would just like to thank the whole Classy team and Southpaw and everyone for joining us. And I'd just like to share that I started really getting interested in this gastrointestinal issues in 2007 after hearing Dr. Bauman talk about it in a symposium in Boston. So it's so special for me to be sharing this webinar with you, Dr. Bauman. So the first thing I had to kind of justify as I started working in this area is why refer to OT? What do we have to offer? And just, I always like to remind everyone that bowel control and continence are important activities of daily living that we need to address just as we would any other area of daily living as occupational therapists. And also just share with you a little bit my trajectory, which has been kind of from clinical practice to research and back, trying to make sense of this information and being able to apply it with families and children to make their lives better. And also the other big thing that I had to always justify and explain is how frequent is this problem, and because it seems that since nobody really talks about poop, we're not so conscious of how frequent it is, but it is very, very frequent, and it's actually one of the most frequent consultations with pediatric gastroenterologists: constipation and fecal incontinence. So the thing about these especially fecal incontinence issues and constipation and other functional defecation issues is that it's not really completely understood. We know that it's multifactorial, but the whole picture is still not quite figured out. What we do know, and which is a very common problem in many of the children that we see in our clinical practice, is that they have retentive fecal incontinence, which is not always identified. So it's incontinence related to constipation when people think it's it's only incontinence, which is a very different clinical picture that needs to be understood before we can do anything about it from an occupational therapy perspective, or transforming habits or whatever. This really has to be taken care of and make sure that there's a gastroenterologist on board to fully understand this picture, because this incontinence is very different from incontinence without stool retention. And the common conventional medical approach is education of the parents so that they understand what's going on, disinfectation of feces, prevention of the reaccumulation of feces, and non-punitive basic behavioral modification strategies. And this is based on abundant evidence, and it seems to work for many children and their families. However, it doesn't always solve the problem. And long-term studies show that 25 to 50% continue to struggle into adulthood. So that's a lot of kids who don't solve their issue in childhood. And this algorithm from the pediatric gastroenterology societies have a couple of dead ends where they come to when they've kind of tried all of their strategies and done all of their tests. And they come to one point where it's consult in mental health and because the pooping problem is not being solved. And I think occupational therapists and our vision, which includes Ayres sensory integration and and sensory issues, can be very helpful here. And then there's another little dead end here, which is when we refer to biofeedback training and more the pelvic floor, and also once again mental health. So so this is another area. This is another little door, I think, where occupational therapists can have a lot to offer. So many of the current treatments include things, once if the basic conventional approach does not work, well, there are things like diet modification that can be considered, physiotherapy for pelvic floor function, have biofeedback kind of treatments to teach you how to control your sphincter muscles, massage, neuromodulation based kind of treatments, psychological therapy, cognitive behavioral interventions, play therapy. Maybe these are the children who really refuse and don't want to participate in the toileting routines are often referred to these kinds of therapies. And then more recently, there's a study and management of intestinal flora, which is becoming a big thing in trying to understand what's happening with children who have these issues. And as an OT, well, I do what I know what to do. I do what I can and how I work. And this is what I did when I was first referred one of these complicated patients that was not responding to conventional treatment. And he was referred to me by a gastroenterologist, which I was already working with around feeding. And he said, please evaluate this child. He came back from the psychologist consult worse. So please, give us your views. So I did what I know how to do. I did the data-driven decision-making process and all of the steps that many of our colleagues have been explaining and featuring here in these Treatment Tuesdays, and kind of put my finger on some of the sensory issues that were getting in the way of why some of these other treatments or other approaches hadn't been working up until now. And we shared, first of all, in 2011, our first impressions, and then in 2013, we shared like our first detailed case study. And so this dear man and dear friend, Eduardo Ramos Polo, he urged me to evaluate more and more of his patients. And he's accompanied me since, and actually was one of my supervisors on the PhD. So it's just been great because he has been really the one who's kind of saying, no, that's not working. No, I need more. No, I need some other input. So as I have developed my work with this team and including gastroenterologists, I think we really have a role here. Occupational therapists with post-professional training in ASI should be considered as part of the interdisciplinary teams who treat children with functional defecation disorders, stool withholding behavior, and other issues around using the toilet, to really identify and treat those underlying sensory difficulties that are, I think, often at the root of the behaviors or the difficulties that they're having. So in the last few years, I've been really taking a deepened look at these behaviors that are very well described in the psychology literature. And I think it's it's interesting to know what others are saying about it, and then looking at it from more of our kind of lens through the sensory integration perspective, and seeing that there's actually a lot in common in when we think of just about the behavior. And then trying to develop a tool that we could better identify those sensory related issues through questionnaires and observations. So that's been really what I've been doing for the last few years, so that we can get to the intervention. So because we need tools, we need to know what the whole story is, but really what we all want is their little kids to feel the urge, hold for a moment, and go sit on the toilet. That's that's what we're helping families achieve. However, we need to understand that there's a lot of steps before we can actually get there. And this is, I think, these kids that are failing conventional treatment are having many underlying issues that haven't been identified, both in gastrointestinal area, sensory area, and many other areas that might not be addressed. And that's why they keep failing different treatments until we get all the pieces together at once and all our little soldiers in line. We can't really get the problem solved. So I always this is the little model I show parents. I said, okay, what's the situation now? Where, how often, how do they feel when they go to the toilet or poop? We need to work with a gastroenterologist to get a normal intestinal transit. That's the basic. At the beginning of the interventions, I don't usually care where they poop. I say, where the cat, in the garden, in the shower, wherever, it doesn't matter. We just need to get that little gut going. And then any underlying factors such as sensory issues or emotional issues or anything else that might be going on also has to be identified and taken care of. And then we'll go little by little trying to get to our goal. But this kind of 0 to 100 kind of approach that sometimes people use, okay, no more diaper, you go to the toilet now, that kind of thing, that doesn't usually work. So with these knowledge and experience and sharing with other professionals over the last few years, I've developed this tool to get my thoughts together and get all of my information organized to make sure that we don't forget any important information that's key to a successful intervention. So things, of course, such as the history of defecation, when did the problem start, to try to identify and pinpoint, did it happen during toilet training? Was there an episode of pain? Something happened? What's the current situation? I want to know the details. I mean, the nitty-gritty details of everything. How, where, when, how often do they cry? Do they want mom? Do they want dad? Do they want granny? Do they want the potty, the pink potty, the blue potty, whatever? And then any concerns around the GI tract, of course, will need to be taken into consideration. Are they currently taking some kind of treatment? Have they tried in the past? Did they abandon it? Why? Did it work? Did it not work? And then our sensory issues. So sensory discrimination / perception / hyporeactivity. And we've got some tools to look at that. We've got some questionnaires. The gastroenterologists have tools to look at that. The THPQ, which is the questionnaire that I developed, has some items for that. And then general kind of appreciation of if children have a perception of the need to go to the toilet or not. Then we've got the reactivity, the hyperreactivity part with our questionnaires, and many of the items on the toileting habit profile questionnaire that I developed are hyperreactivity items. And then also visceral hyperreactivity is an area that's being documented more and more and within the field. Then we've got feeding, which should be taken into consideration also. And then we've got pelvic floor, muscle control kind of issues, and then the challenging toileting behaviors and attitudes that might be getting in the way. And then we shouldn't forget that trauma, attachment, other emotional issues can also get in the way of your gastrointestinal function or your readiness to use the toilet. And so I think, and we have to remember that each one of these little squares can actually be many, many things. Like, we have to remember that, if we're talking about sensory, we've got our whole sensory clinical reasoning to do. If we're talking about feeding, we've got our whole clinical reasoning to do around feeding. So this is something that we need to keep in mind. And these other areas also have their whole slew of tests maybe to get done also. But what I'd like to point out here is that I think that some of the kids that are maybe failing kind of the pelvic floor muscle control kind of therapies, what I'm seeing clinically, and after talking to some colleagues recently, I'm thinking that it's more of a question of, perception, praxis issue, and they can't get their little bodies to figure out what's happening down there and how to get the poop out, or even realizing that they have a need to poop. And then the little kiddos that are having issues more around the behaviors with toileting, who refuse, who are fearful, who have rituals, I'm seeing that many of them are having hyperreactivity in the tactile system, but also in other systems, and also, the whole defecation sensations as such, which, I won't get into details, but that's a very sensitive area of your body, right? So questionnaires like the sensory profile, for example, have an oral section where it's full of items around food and textures of food, et cetera, et cetera. Well, the THPQ would be the pooping section of these for a sensory complement, a component of a sensory questionnaire, but really the pooping and the toileting component. And so, yes, the texture and the hardness of poop and the seat and everything else that goes on when you poop has to be considered in sensory reactivity. So, like I said, each one of these squares can have a lot more to look at. And then when we do our treatment plan, we have to look at all of these different aspects to really get down to the nitty-gritty and do the treatment that we need to do after we've identified what's going on. So many times it's a multidisciplinary plan where I'm working closely with the gastroenterologist. So establishing a relationship of trust is key. Often these kids have been they're burnt out, I think, Do you want to poop? No. Why? Because if I say yes, they're just going to rush me off to sit on the toilet, and I hate sitting on the toilet. So I'm going to say no. Have you pooped? I've pooped in my pants, but I'm not going to say yes because I'm going to be, punished or whatever. So I just say no. And so it just gets so messy. The family dynamics get really messy. So I try to, first of all, really clean that up and establish a relationship of trust between the child and the family, and that everybody understands the problem. So these problematic behaviors and what parents do and what children do are very, very important to understand, because they can actually make the problem worse. For example, if the caregiver has excessive expectations, for example, in the case of a child who has retentive fecal incontinence and the child gets punished for pooping in their pants, it's completely involuntary. It's completely impossible to control that. So you have to have, a GI evaluation and treatment to get that cleared out, and many other issues around this, dynamic between the parents and the child. And then if we do see that there are sensory problems, we'll do our DDDM as we usually do, and kind of see what is it that's getting in the way. Is it the reactivity to tactile input that's getting in the way of accepting sitting on the toilet with your little bum in the air and no diaper on? Is it lack of body awareness and perception discrimination issues that's getting in the way of knowing how to push and squeeze your muscles, or knowing that it's time to go to the toilet? So it would be, I would say, just as we use this approach when we're talking about issues around feeding or dressing or handwriting, we do this analysis, you know, and it's not, we're not dressing therapists, we're not handwriting therapists, we're occupational therapists, and we do this whole analysis and just try to pinpoint the issue that's getting in the way, and we set out our hypothesis, and then we work on that hypothesis with all of the data that we've collected to make sure that we're working from a strong evidence base. So then, whether it's one thing or another, the therapies can look very different, you know. So for this little girl who's more in a, you know, I don't feel it and I don't know how to push it out kind of with some body awareness issues, well, a therapy might look a little more like this, where we're using a lot of those muscles and bouncing on those little that ball and doing a lot of work like that. Whereas for a little girl who's more with a lot of hyper reactivity to touch, who's getting in the way of accepting the sensations related to pooping and peeing, and this little girl was also withholding pee, she was having a lot of issues, and so it looks very different. They're more oriented to those tactile issues, a lot of deep touch and a lot of gentle rocking, and then I don't really have to do anything about her toileting as such, because she just goes home and says, Mom, I'm gonna have it. Very relaxed. But I didn't actually have to work on pooping or peeing at all with her. So, and then we try to address all of the other things that come up with these kids, like, you know, refusing to sit on the toilet and making sure people and parents don't force them. We give them all kinds of strategies to go in a very progressive way towards our goal. We help through routines and reminders and little schedules to help kids become aware of the need to poop. And we're learning more and more about interoception, and I think that's going to be something that we're going to be able to include more and more in our therapies as well, because we're seeing that touch and proprioception have a lot to do with interoception. So that's becoming very interesting to learn more about this and include it in our clinical reasoning. And that's about what I had to tell you. That's about it for me.
That's really great. So interesting to see your research and the systematic way you've approached this really critical topic. I know in our practice, I would say once a week we have a child with this issue, and you know, in my evaluations, every other child I evaluate. Yeah,
very, very common. Isabel, thank you. There was a couple questions. One was where people might obtain the questionnaire, if that's possible. So
yeah, they're all everything's published, so I'd be happy to share those publications with you, no problem.
Okay, and Marco did post some, so I don't know, we can maybe determine where the easiest way for people to find the questionnaire is. And then I don't know if you can see in the chat, there was another question about, and I don't know, maybe we should wait but there was a question about children who run to the corner to defecate in their pull-ups, but not wanting to sit on the toilet. I know that's a common issue that comes up. If you want to
Well, that's
address
these
that.
rituals
Mhm.
and these, these going to the corner or hiding. This is very common, and I've seen it linked to children who have hyperreactivity to touch often, but many other sensations. And so it's often my interpretation is just let me be. I'm going to do something that's really, really hard for me. And I just want to do it my way. And, I don't want to be interrupted. So just as, they have many children who with hyperreactivity have rituals and very rigid kind of habits in other activities of daily living, I see this very often linked to hyperreactivity.
Dr. Bauman, I'd love to hear what you're thinking.
Okay, well, thank you very much, Isabel. That was really fascinating. And frankly, I learned a lot. So I'm very grateful. Thank you very much. I also wanted to apologize to the audience for not putting up any slides. The slides I have are fairly extensive, and I would rather, if somebody would like to have copies of them at the end of all of this or part of them, I'm happy to share them. But I didn't get around to sort of paring them down. So you're sort of stuck listening to me a little bit. And I will be glad, as I said, to share the slides a little bit later. So if you see myself moving back and forth, I've got some notes here that are just to keep me on track as best I can. So as Zoe already started to say, of coming to this largely from the world of autism. But frankly, children, adolescents, and adults, and frankly, we're also getting much more involved with adults. So this is just not a childhood problem from the terms of healthcare issues and what we call medical comorbidities, things that medical concerns that individuals who have any kind of disability could possibly have. And there are, I think the stereotype that we often think about is, if you're autism, if you're cerebral palsy, if you've got muscular dystrophy, whatever, it's some kind of neurological something. And it's hard for people to kind of get beyond the concept of maybe there's more going on here than meets the eye. So this is where we all kind of got involved at some point, and largely a lot of this came out of the fact that I was fortunate enough to be part of a multidisciplinary team, which included occupational therapy, speech and language, gastroenterology, psychiatry, so forth and so on. So one learns from other people. And I've certainly, when my neurology training, was not trained to do 9/10 of the things that we're about to talk about, but I did basically learn from others. And fortunately, I think we're beginning to expand the field a little bit more than we used to, which is good news. But I still think that there's still very narrow views about what some of these folks with disabilities may have going. So what I'd like to do is to talk about a couple of medical comorbidities. Certainly not everything, that we could possibly talk about today, but just to bring up the fact that individuals, certainly on the autism spectrum, but also those with developmental disabilities of many other kinds, may not always present with symptoms that are terribly obvious to the specialist who has been trained in whatever field they've been trained in. And I find this really, I don't want to get snarky here, but I find it annoying that medical schools are really not addressing this, or even medical training programs are really not addressing this as well as they should. And as most of you know, the autism prevalence rates, at least in the United States, is now listed as something like 1 in 54. Well, even if you're a dermatologist or you're an allergist or whatever you are, it's pretty hard to believe that you're not somehow someday going to come across somebody who's got a developmental disability of one type or another. And it's just unfortunate, I think, that our medical schools are not doing a better job about training these folks. I think they're beginning to see the light, by the way, but I don't think we're quite there. So anyway, we're going to just talk about a few things here that are often seen, not certainly 100%, but often seen in a number of folks who have developmental disabilities. And one of the first, of course, is seizure disorders. And I'm bringing that up because I'm a neurologist and I'm frequently asked to see somebody who, quote, might have a seizure. And frequently somebody is describing a behavior of one type or another. Most commonly, I would say, staring spells. So-and-so is staring off into space. They don't respond to their name. And I think they might be having seizures. And some people on this call may have already heard some of my stories, so I apologize if I'm repeating. But one of my favorite stories is the fact that I had a little boy that came when he was 4 years old, and I was the third neurologist. And the mother describes these events, and as a neurologist, you think, oh yeah, that sounds like seizure to me. And then about 2/3 through the visit, she said, oh, I happen to have a video of one of these episodes on my cell phone. So she turns on the cell phone and I looked at it and I said, this is not seizure, this is GI. And this was a little boy who was sort of all curled up on the floor, clearly having abdominal pain, frankly. And so I referred him to a gastroenterologist the next week who fortunately had a cancellation. She did an endoscopy. And I got a call back that said esophagitis, good call. So this was a little boy that was being treated for a seizure that in fact he did not have, he had something else. So one of my favorite ways of looking at this, if somebody's got some kind of concern about a behavior that a patient, be it a child, adolescent, or adult, is demonstrating, please, everybody's got a cell phone these days. All one has to do is click on the cell phone and get a picture that you can show somebody, because most of us are locked into our specialty areas. Our brain just says, okay, this is a seizure and I'm going to go for it, when in fact it may really be something else. And I'm not going to say that it's always going to be gastrointestinal, but it could be something else. And frankly, a picture is worth 1,000 words. So my biggest recommendation is that if there's any suspicion that one of your patients might be having a seizure, just grab a video or have the parent grab a video that he or she can share with a physician. EEGs, as you know, are common, that we use those to try to rule out whether someone has a seizure. A routine EEG is fairly short. You get this person all hooked up in the laboratory, takes about, the whole event is probably about an hour, but the actual EEG is something like 20 minutes. Well, it would be very easy to miss something on that. So then we've gone to 24-hour EEGs. So that assumes that you're going to have a child who may, in some cases, have sensory issues and not want anything on their head, to walk around for 24 hours with this thing on their head. So that's a little challenging. It can be done, but still we could still miss something. And sometimes that's even misinterpreted, that there can be people who have abnormalities on their EEG who do not have seizures, and there could be people who have perfectly normal EEGs who have seizures. And the latter could be that the focus of the seizure is too far away from the electrodes to get picked up. So really, there are many ways of trying to sort this out, but my biggest recommendation to a therapist or to another colleague would be to recommend to your patient, please just ask somebody to get a video of what it is they're describing so that we have a better idea of what's going on. So then there's sleep disorders, and at least a lot of the kids that I see have difficulty getting to sleep. They have difficulty staying asleep. And if the child or the adolescent isn't sleeping, then nobody is sleeping in the house, and that's pretty disruptive for everybody. And there are probably many reasons why this can be so. Oftentimes it's interpreted as a behavior problem. Sometimes it is. I'm not saying that there can't be issues like that. But again, it could be gastrointestinal. So for example, you could have gastroesophageal reflux disease. So when you lie down, gastric acids slither back up into your esophagus, get into the back of your throat and wake you up, or keep you from wanting to fall asleep because you know this is going to be uncomfortable. So that's a problem. Certainly constipation, which Isabel described very well, can also be an interfering factor because it's uncomfortable. There could be kids who have big tonsils and adenoids, and so they have trouble breathing. There could be kids who have allergies or sensory processing issues, so they need deep pressure or they itch a lot, or there could be a whole host of reasons why somebody could be having sleep problems. And I think before one just assumes that this is a behavior problem, one has to at least try to look into, is there something medical going on here that's contributing? Otherwise, we're probably going to be treating the wrong thing. So sleep problems are a big issue and need to be addressed. Then we have the gastrointestinal problems, which Isabel has described extensively. And certainly constipation is one of the most common. But we also have children with diarrhea. We talked a little bit briefly about upper GI problems, which is the esophagitis or the reflux, and then lower GI problems, which we can have all kinds of diseases of the gut, what's called Crohn's disease, during colitis, and then there are motility problems, which could be contributing to some of the constipation that she's described so well, is that somehow the neurology of the gut just isn't pushing the stool through the way it should. The muscles of the gut are not working the way they should. And then there's something that's called the tight rectal sphincter. That is the sphincter to allow the stool to emerge from the body is just too tight. And so that causes a lot of pain and distress for the patient. So there are a number of areas here that really need to be investigated. If somebody is showing odd behaviors, sometimes these kids will in fact present with behavior problems without any of these other symptoms that we're describing here. And as some of you probably already know, my go-to situation is that if some child, adolescent, and adult shows up in my office with a behavior problem, my almost second recommendation is you need to see a gastroenterologist. And I will, again, one more anecdote if I have time, I guess I do, this was a young adult, a 21-year-old woman with autism who's hypoverbal, and a lot of these folks cannot tell us they feel pain, uncomfortable, and I think also they have sensory issues that I've highlighted already, where they can't even tell you where it might be or point to it. So there's sort of a sensory unawareness, if you will, about what's bothering them. So anyway, this young woman comes in, and the one thing she can say as she's hitting her head is head hurts. So the parents are saying, we think our daughter has a headache. And I said, well, I know you're going to think this is a very weird recommendation, but I think your daughter needs to see a gastroenterologist. Fortunately, they were kind enough to follow through. Long story short, got worked up and had an esophagitis. The esophagitis got treated, and there was no more hitting her head and no more head hurts commented. So I think in that case, the head hurts, hitting your head, meant I hurt someplace. I feel uncomfortable, and this is what I'm telling you, that I don't feel well. Is sort of what was the message. It wasn't that the head hurts per se. That was the one thing she could say to try to indicate that there was a problem. So we have to look beyond the obvious here about what's going on and think out of the box. So one of the other areas of concern is the upper GI tract issue. And we talked a little bit about sleep, but there also can be other behaviors that some of these folks will exhibit. So a lot of gulping, swallowing, kinds of behaviors, facial grimacing can be part of the secret, sometimes just tapping on the chest, sometimes pressing on the abdomen. I remember one time we had a patient come in who was 24 years old. He made a beeline for the sink and pressed his abdomen against the sink. And the occupational therapist, who happened to be in the office with me seeing patients that day, looked at me. She says, I think he's got GI tract problems. And I said, yeah, I think you're right. And indeed, he did. So there are signals that these folks are giving us that are not particularly obvious. And I guess we have to kind of think out of the box here. A lot of the other signals that we hear about is chewing on non-edibles. Okay, chewing on your sleeve, chewing on a lot of us give chewies because we feel that helping the sensory feel. But the theory is that if you're chewing on a non-edible, you're creating saliva, and saliva then is soothing to an irritated esophagus. So it could be somebody who eats snacks a lot. It could be somebody who drinks a lot. It could be somebody who just chews on things, but anything that's going to be there to soothe the esophagus will be a signal that maybe we need to look beyond whatever this behavior is that the person is exhibiting. So another area of concern is teenage girls. And oftentimes I will get the story of everything was fine until she started having her menstrual period. And now her behavior is terrible. Sometimes they will tell you that it coincides with the menstrual period. Sometimes they'll tell you that it has nothing, they don't think it's got anything to do with anything. We did start sending these girls to what was then called a neuroendocrinologist. That's somebody who understands both neurology and hormonal imbalance or hormonal systems. Anyway, this man who was a gift to help us found out that many of these girls were exhibiting imbalances between their progesterone and their estrogen. And if that got rebalanced, then the behaviors went away. So unfortunately, this person who was my right-hand person has retired. I don't know how he had the nerve to retire, but he did. But anyway, sorry. So now I think the goal is to find an endocrinologist or a gynecologist who will at least listen to you and say, okay, we need to try to look at these hormonal imbalances to see if there's something there that we need to treat. But there is a subgroup of females, particularly the teenagers, that's been our experience, that have had these issues. And it's not something where you're just going to say, let's just give her medication. Let's find out what the hormonal, let's find out what the hormonal story is and then follow through. And then there are children who have been continent from a urinary point of view for a long period of time, who start having accidents. And people, the initial response usually is, this is behavioral. Something's going on, he's anxious, there's something going on at home, there's something going on at school. Well, this has turned out that too may be so. But on the other hand, it turns out that there seem to be a subset of these kids who have what we call spastic bladders. And why they get spastic bladders, I have no idea. But the bladder just doesn't seem to want to empty the way it should. And it's been, the ones that we've seen mostly have been largely in those who are preschool, pre-kindergarten, pre-adolescent. The phone's ringing in the background. I thought I disconnected, and I'm sorry. But in any case, there are individuals who are pre-adolescent to a large extent. Sorry, pre-adolescent. And we've sent them now to a urologist, has found spastic bladders. These are treatable. And it's something that it should not be ignored. And it is a treatable thing. There are medications that can treat it. And once medications are in there, the kids move on. So I apologize for the phone in the background. I thought I'd done my best, but I obviously didn't do well enough. In any case, metabolic issues are another concern. And there's now a growing body of research now that is talking about the association between some of these developmental disabilities and what are called mitochondrial disorders. Mitochondria are the inner engines for every cell in your body. And the particular work that's being associated with autism right now is coming out of Arizona. And if you want to look up something that's recent, the work is being done by a man named Dr. Richard Frye, F-R-Y-E, in Arizona. And his work has been primarily related to the autistic kids. And he has equated much of this to the children who go through early regression, which is a story that many of us have heard for a while. My child looked fine until about 18 months of age or till 2 years, when he or she lost their language or we lost the skills that we previously had. It doesn't necessarily mean that's the case, but that's where he's beginning to see some relationships. In any case, mitochondria are important, and they're not necessarily just associated with autism. They can be associated with anything. And in fact, I have some typically developing young adults who have mitochondrial disorders of one type or another. Well, the symptoms that we typically equate with that, what would make me want to evaluate somebody for a possible mitochondrial disorder? One of the first ones is poor physical endurance. So we have a child or an adolescent or even an adult who just doesn't seem to have a lot of energy. So in a child's case, it would be, we're going out for a walk and he or she wants to get picked up and put in a stroller after we've taken 2 or 3 steps. They're just not, they just don't have the endurance that somebody would expect. Somebody who is a late walker. So most kids on the autism spectrum walk on time. They certainly have motor issues, but somehow they walk on time. If you've got somebody who doesn't walk until 24 months of age or later, then that needs to be investigated. And that is a red flag for a lot of us. Repeated regressions. So you've got the regression in autism that you see or hear about between 18 and 24 months of age. But let's say you've got a 7-year-old who does that 3 or 4 times a year. That's not normal. That somebody needs to follow up on that. Why is this kid losing skills that he or she has had and multiple times during a year? So that's another red flag. Kids who are in fabulous programs, 24/7, great parents carrying through, good therapists doing a good job, and they're just not making any progress. I mean, you ought to make some progress just on the basis of development alone. And if you've got a situation here where nobody's, despite everything that's going on, not much is happening, then something's working against you. And you have to think about what is it that's keeping that child from moving forward and making developmental gains. And so one of the things that we've come up with is this mitochondrial situation. And then lastly, our kids who have multiple organ systems involved, somebody who's got a gastrointestinal problem, somebody's got allergies, they've got maybe cardiac problems of some kind, they've got neurologic problems of some kind, they've got multiple organ systems involved here. So you have to start thinking more broadly about what's covering all of those bases. So there are laboratory studies that can be done. The best way to rule this in or rule out is a muscle biopsy. Obviously, most people don't want to have a muscle biopsy because it's invasive and it's a surgical problem. So what we've done is we do some basic laboratory studies. Many of times those come back as negative, in which case then we will do what I call a 3-month trial on our quote mitochondrial cocktail, which is a group of substances that are compounded by a compounding pharmacist. And I know I'm saying this sometimes when I give a talk about please don't tell your therapist, please don't tell your teacher, don't tell anybody that you're doing this, because I want to get an objective opinion about whether or not this is, they're seeing any changes. And, if somebody comes back in a month or 2 and says, he's really doing well, I mean, he's doing all what are making this progress that I haven't seen before, then yeah, I think we've made that's a signal that maybe we're doing the right thing. And I'm trying to avoid the placebo effect. The last time I said that at a meeting, some of the teaching staff who were in the audience got very insulted because they feel that they want to know everything. I want you to know everything too, but I also need to be able to get an objective opinion. So I apologize to those who are insulted, but I think from a medical perspective, I need to be sure that what I'm doing is correct. And then I guess the last comment that I would make is psychopharmacology. There are many children, adolescents, and adults who have sort of social emotional issues, obviously. But one of the most common is anxiety. Another more common one is attention deficit disorder. And I guess my message here is I think we need to be sure that we've ruled out whatever medical things may be contributing to some of these symptoms before we suddenly run off and start loading some of these people up with medications. Medications absolutely have their place. I think it's important that they be included. I really try very hard to refer to psychiatrists who have good knowledge of individuals with disabilities, because a lot of these people do not respond to medications in the same way as typically developing people do. So it's a matter of finding the right person and to do the right intervention. One quick addition here, I want to just throw one thing out. There are many other medical issues that should be included. So for example, obesity, osteoporosis, which is a very interesting situation because a lot of people are putting in children, particularly on special diets that are not high in calcium. And it's now become apparent that there's a subset of these children are becoming calcium deficient. And by the time they're 12 years old, they've got bones that look like they're 45. So, we have to be very careful about dietary interventions, whatever that may be. Otitis media, certainly ear infections can be a problem. Pandas, I expect many of you know what pandas is. That's an immune disorder that's relationship to strep infections, can cause behaviors such as obsessive compulsive disorder and developmental delays. It too is treatable, but very complicated. Some people don't believe in it. I do believe in it, and I've seen it respond. Depending upon where you live, there's something called Lyme disease that's due to ticks that needs to be treated. Then we get people who have dental problems, injuries, and so forth. Anything that any typical person can have, these folks can have. And I guess the message here is we just need to be alert as to the fact that many individuals who are developmentally disabled, maybe who can or cannot speak to us, may present with atypical symptoms. I'll be glad to take any questions, and thank you for listening to me. I appreciate it. And thanks, by the way, for letting me be involved in this. I've learned a lot. Thank you.
Wow. that was amazing. That's such a, I'm so impressed. What I really love about this talk, and we've heard you before, is looking beyond the obvious diagnosis of cerebral palsy, autism, whatever that is, and go, well, there's other things going on. And, so often we get these presenting concerns. Like, I think now it's so common that the child has a behavior disorder and they have 20, 40 hours of behavioral intervention. And you go, but that child hasn't pooped for a week and he does better after he empties out.
Right.
Like, okay, well, is this a behavioral problem, or is this a metabolic or motility or something else?
Exactly. Good point.
Exactly.
And thank you for mentioning adults, Dr. Bauman, too. I mean, I think, these are lifelong issues, and it's been so great to have your insights for what happens as the kids go through adolescence and hormonal changes and into older ages too. So that's really important.
Adults are, yes, well, that's probably a topic for another day, but adults really are being underserved. And I belong to a group now, that international group that's looking at aging in adults. And it's really pretty apparent that most of them do not get to even the routine surveys, I guess. So how many adult women who have a developmental disability get mammograms? How many adults with developmental disabilities get routine colonoscopies? Probably not many, okay? And so I think it's a field that really needs to be looked at. So thank you for letting me make that kind of statement.
Thank you. Those of you who are asking about slides and links, we will gather what we can and make sure that we share those on our website. So.
I have a child I just saw yesterday. I want to ask you about him, but I know we're out of time. 8 years old, and he was as big as I am, tall as I am, twice as round, short of breath, eczema. Parents said no health concerns. Okay, but that's for another day. Yeah.
Oh my goodness. Okay.
I know. Like, okay, and where do we go? I'll be sending him to Casa Colina.
Okay. We'll have a little chat.
I do. I would love some help.
Sure.
And I'm sure all of these people that are here have their own cases and so many questions, and we just do our best for our families. So anyway, thank you. Thank you all. Thank you to Southpaw and to Classy, and you guys are amazing for the work you've done.
Well, thank you for having us. And Isabella, I thoroughly enjoyed your talk. So thank you. I learned a lot. Thank you. That was really helpful.
Thank you for having me, and of course, always so enjoyable to hear your talk as well. It's just a continuous source of inspiration.
So, Suzanne, did you want to mention the conference one more time? I don't know.
Well,
did you have
before
that slide?
that,
And Marco,
Okay.
I'm going to turn it to Marco. He's
I want, yeah, I was trying to share, but seems my computer is not allowing that. Let me see. No. Okay, so I was just, my computer is not in a mood today. I'm just gonna say the names of the winners, and just a brief reminder that we raffle this process with everyone who is attending, especially to the ones that stick to the last minute. Here we go. Thank you, Suzanne. So our Easy Starter Kit, the winner is Tanya BB, and I hope I'm saying this right. I'm writing her name on the chat, and Tanya, you can contact Melissa Coleman for your prizes, all the information you need to get your Easy Starter Kit. And our Sotpa gift today goes to Dvordvik in Croatia.
you're the lucky-
Dawar and Tanya, that's so great.
That's so awesome.
Congratulations to both of you. Please contact Melissa. I think Melissa, yes, Melissa dropped her email or information there. So we'll be in touch to get this process to you. Congratulations.
Okay, and then just really quick, I'm going to go back to our initial slide. Just the last one in this series is December 7th with Dr. Tina Champagne. We're going to talk about health again with trauma and attachment, mental health, and you know, I have a little surprise for everybody. Nobody knows yet, but I'm doing a little surprise for the holidays for everybody. So please join us on December 7th. And then we have this baby coming up. You want to talk about it?
Well, we just are so thrilled to again remind everyone that we will finally have our big Congress next July 14th to the 16th in 2022, a delayed celebration of Dr. Ayres' 100th birthday, but with a fabulous program that's in process now. We will have an in-person, we hope, a substantial gathering of our colleagues around the world, as well as a virtual option. So look for more information soon.
There you go. And that's a wrap. So thanks, everybody.
Thank you so much, Dr.
Thank you.
Bauman, Dr.
Thank you.
Beaudry. It was
Great to
just
see everybody.
wonderful to have you. And thanks for everyone joining us.
Great. It was
Thank
great
you.
to see you all. Thank you. Thank you,
Thank
Marco.
you.
Bye.
Thank you, Dr.
Thank
Bauman.
you.
Thank you.
Bye, Isabel. Thank you so
you.
much.
Okay, bye-bye.
Bye.
Bye.